Hello, everybody. I am Dr. Santosh Kumar Dora. I
Hello,
work at
everybody.
Asian Heart Institute, Mumbai. Let me introduce you about the next session, which is on reading cardiac MRI. As you know, cardiac MRI is a very important diagnostic tool, especially when we are dealing with ventricular arrhythmias, especially in non-ischemic heart disease. And in this session, to discuss about this reading cardiac MRI, we have four eminent speakers. The first speaker will be Dr. Bhavin Shankaria. He is an eminent radiologist from Mumbai, and he will be speaking on the role of cardiac MRI in rhythmogenic right ventricular cardiomyopathy, rhythmogenic left ventricular cardiomyopathy, and athletic heart. The next speaker will be, again, one of the finest cardiologists in Mumbai, Dr. Nitin Burkule. He practices at Jupiter Hospital in Thane, Mumbai, and he will be speaking on the role of cardiac MRI in myocarditis. The third speaker will be Dr. Johan Christopher. He is a cardiologist in Hyderabad, practices at Care Hospital, and he will be speaking on the role of cardiac MRI in sarcoidosis and amyloidosis. The fourth speaker is international speaker, very renowned Dr. Milind Desai. He's based in the USA and he practices at Cleveland Clinic. He has done a lot of work on hypertrophic cardiomyopathy, and he will be speaking on the role of cardiac MRI in managing cases of hypertrophic cardiomyopathy and non-compaction of ventricle. I'm sure this is a very interesting session, and stay tuned for it and enjoy this session. Thank you very much.
Should I share my screen and start? Okay, am I audible? Can somebody just tell me?
Yes, sir, loud and clear.
Perfect. So today it's all about cases. I have three questions, and I'm assuming somebody is managing the response system. The first question, for those of you who are seeing this, there are 6 cases that I'm going to show one after the other. And you need to figure out which one of these is ARVC. So they go as A, B, C, D, E, F, and I'll just run through these, right? Which of these 6 cases is ARVC? And I'll present the actual response case at the end, or the response slide at the end. So this is a 21-year-old with a dilated right ventricle. This is a 4-chamber view that you can see here, and a view through the pulmonary artery. Is this ARVC or not, is what you need to be answering later. This is the second case, a 46-year-old with a complex tachycardia. That's the 4-chamber on your left. That's the short axis. And you can see that it is a biventricular pathology, and both the LV and the RV are abnormal. Is this ARVC or not? This is the third case of a patient who's in failure, 53-year-old. You can see that there's a biventricular pathology involving the LV and the RV. That's the short axis, the 4-chamber and the 2-chamber. Is this ARVC or not? That's the fourth question here. And again, this is a 57-year-old with RV tachycardia. There's predominant RV involvement. The LV seems relatively normal. And again, the question is this ARVC or not? Then we have the fourth patient, a 60-year-old with acute chest pain. That's the short axis. Again, a primary RV pathology with relatively normal LV. You can see swirling of blood in the RV and RA. Is this ARVC or not? And the fifth, the last one, the sixth, or F, is a 31-year-old with abnormal RV on echo. And you can see this abnormally flattened RV, though it's contracting well, with a prominent RA. some other abnormalities, and you need to answer, is this ARVC or not? So the question slide is here. I showed you 6 cases. You were to make up your mind on any of these. Which of these is ARVC? A, B, C, D, E, F. Okay, so what happens now? Is there an automatic response system? How does this work?
Yes, sir. We will tell you what options have gone through.
Please, I'll be waiting till then, yeah? Okay, so while
so there are 50% for option A and 50% for option F.
Option F.
Yeah, 50% for option A and 50% for option F.
So that's what 2 people have answered, and 1 is for A and 1 is for F. I mean, how many people have answered? Okay, let's move on. Let's not waste time. So that's the first case of this 21-year-old with a dilated RV. And if we see this, the RV is dilated, the LV is normal. And clearly the MPA is dilated. The patient seems to have pulmonary hypertension. And in a young patient, this patient did not have RV tachycardia or any other findings suggestive of ARVC, but our ARVC protocol always has a QPQS, because we've seen that patients are referred to rule out ARVC, but often land up with all kinds of other RV related pathologies. And if you see here, the absolute stroke volume, the QPQS is 3, tells us there's a shunt, and we found this anomalous right superior pulmonary vein draining into the SVC with a sinus venosus, ASD. The second patient with a 46-year-old with a complex tachycardia has biventricular disease. Now, if you see that the RV is abnormal, but doesn't show any pseudocirculation, aneurysms, etc., and the late GAD shows abnormal mid-myocardial epicardial enhancement, both of the LV and of the RV, you could turn around and say, can't this be ARVC with ALVC? Well, it could be, but the morphology doesn't fit in, and the patient had necrotic lymphadenopathy that we biopsied, turned out to be tuberculosis. So this is granulomatous cardiomyopathy. For all practical purposes would have been treated as sarcoid outside of India, but as we know in India, tuberculosis behaves in the same way as sarcoid in many instances. This is a 53-year-old man in failure. There is thickening of the myocardium, and that's the abnormality. So clearly this does not fit into ARVC. High T1 values, abnormal enhancement patterns that are typical of amyloidosis. And so this is an infiltrative cardiomyopathy. This was the fourth question. The RVEF was 28%. You can see the regional dyskinesia, the accordion-like irregularity of the anterior wall, a little bit of pseudocirculation on systole. LV is normal. Patient had typical ECG findings as well, and this is ARVC. The fifth patient had an acute chest pain. RV is not contracting. The LV is contracting. But on the late GAD, there was an inferior wall infarct in the basal LV, and then the entire RV was pretty much infarcted. So this is an acute RCA territory infarct involving the RV. And lastly, this patient, a 31-year-old with abnormal RV on echo, you can see that there is an abnormality of the Ziphy sternum. This patient had a pectus abnormality with a straight back morphology. You can see that the anteroposterior diameter is reduced, and these often cause flattening of the RV that can sometimes look abnormal on echo. And once in a while, maybe once or twice a year, these patients get referred for evaluation of RV pathology. There's really nothing here. It's just absolutely normal. So these were the 6 options that we had, and of these, D was ARVC. And ARVC very quickly is progressive degeneration of the right ventricle with fibrous or fatty replacement. We know it's inherited, and 1:5,000 is the epidemiology. These are the clinical features, and the culprit gene can be identified in about one-third to half of patients. We know that the 2010 task force criteria are still used, and I won't go into details, but most of this is based on the clinical parameters, and then MR has a contribution as well, and we'll come to that in a minute. So the second question here is that when we look at the task force criteria for the diagnosis of ARVC on MRI, which is not a criterion? Regional RV dyskinesia, fat in the myocardium, RV ejection fraction less than 40, or RV end diastolic volume upon body surface area of greater than 110, etc. So can we run the response system?
Yes, sir, it's on.
Very nice. So what we want to know is one of these points is not included as a task force criterion for the diagnosis of ARVC. And if you know which one that is, then you can answer this. Do we have the answers now?
Yeah, sir. Option A is 40%, option B is again 40%, and 20% for option 3.
All right. Okay. So we're basically, so nobody for option B.
No, sir.
Okay, great. So regional RV dyskinesia is best seen in the anterior inferior walls and the angles. The axial scans help here. You can see a patient with this accordion-like anterior wall. The angle actually shows kind of a pseudo-sacculation in RV systole. You compare that to a normal contractility, that is abnormal. Again, here you can see that's normal, and that's the abnormal irregularity and the pseudo-sacculation that you see here in the anterior wall. So that's a defined sign. What about myocardial fat? So when I was training many years ago, it was an integral part of the diagnosis as far as the 94 criteria were concerned, but it is an unreliable sign. You may see fat in normal individuals. All patients with ARVC may not have fat. Epicardial fat sometimes simulates intramyocardial fat. There is a high inter-observer variability, but we've now seen that on the T1 map, we can see fat better. So this is a patient with ARVC with intramyocardial fat. It's bright on T1, beautifully seen here. And if you see it in the septum, as you see in this patient, then you can pretty much say that it's ARVC, but nevertheless, epicardial fat, like you see here, merges with the myocardium and can be a challenging diagnosis. Late GAT, delayed enhancement, is not part of the task force criteria, and I just put it in here. It wasn't even part of the quiz question. We know that abnormal enhancement implies fibrosis, as we see here, has a poorer prognosis, but it's not part of the criteria because it's still not robust, and cardiac MR with contrast is still not easily available. But on the cine images, you can see the dyskinesia, the pseudo-sacculation, etc. beautifully. Reduced function is a criterion. You can see here a very poor RVEF. You can see these microaneurysms and pseudo-sacculation as well. And so these are your task force criteria. Again, these are all very well known, so I won't go into details except to say that myocardial fat is not part of these criteria. And that also hasn't particularly changed in the 5-year ARVC risk score that was published 2 years ago, where of the 8 criteria to look at risk for ventricular arrhythmias or sudden cardiac death, it's only the RV ejection fraction that is used. So the answer is fat in the myocardium. The last question, and a quick one here. Please look at this image. This is a patient with ARVC. You can see the irregularity in the accordion-like anterior wall. You can see the subtle pseudosaculations and systole. And that's the late GAT, where you can see the little bit of abnormal enhancement along the anterior wall and septum, but there's something else happening in the left ventricle. Please look at this carefully. And your question is here, what is this? Is this ARVC with ALVC? Is this biventricular granulomatous cardiomyopathy? Are these the sequelae of earlier viral myocarditis? Or is this RCA infarction with circumflex infarction? And the question is whether what looks like ARVC is really ARVC or it's one of these two. So can we run the question? Oh, it's already running. All right, great. Do we have answers? Is it ARVC with ALVC or BC or D?
Yeah, sir, we have ARVC with ALVC in 33% of the cases, biventricular granulomatous cardiomyopathy in 33% of the cases, and RCA LCX infarct in 33% of the cases. So
You know, I sometimes wonder if people are even listening. I actually started by saying this is a patient with ARVC. So, I mean, clearly the answer is A. Seriously. I guess it's this post-lunch, post-break phenomenon, though I thought that only occurred when you do in-person meetings. But anyway, so these are classic findings of ARVC, and in that context, we have a focal area of abnormality in the mid-lateral wall with this abnormal mid-myocardial enhancement that is seen here. And when you have a confirmed ARVC, both clinically and on ECG and other criteria and MR, then what we see here would typically imply arrhythmogenic left ventricular cardiomyopathy. You do get different patterns. You can have ARVC with normal LV, which is in the majority of patients. Then you have ARVC with limited LV involvement, which we saw in our patient. And then you can have LV predominant ALVC, which can be mistaken for many other diagnoses, including sarcoid and granulomatous cardiomyopathies. And it needs to be a combined diagnosis made based on multiple criteria. But the more the LV involvement, the worse the prognosis and the more the likelihood of arrhythmias and sudden cardiac death. So today's focus was on ARVC and its mimics, the diagnosis of ARVC and ARVC and ALVC. I did not include athlete's heart because at least in my practice, and we have a substantial practice, but we don't see athletes still coming for CMR. And I know that in most, I did poll my colleagues in other institutions, etc., and we still don't have athletes coming for CMR. And so we don't really see too much of athlete's heart. And so I have left it out. Have a great meeting. Thank you so much for your attention.
Who's the moderator?
Shall I share my screen, please?
yeah, thank you so much, sir. Sir, yeah, you can start.
Are my slides visible? Am I audible?
Yeah. Everything
Are
is
the
clear.
slides visible?
Yeah.
Okay. Once again, thank you IHRS for this kind invitation, especially Dr. Ashish. Special thanks to Dr. Nitin for letting me go a little ahead. We'll be talking about imaging, and my focus is going to be on the inflammatory cardiomyopathies. We're going to be talking about sarcoid and amyloid. And this is our imaging center at Hyderabad. Once again, thanks for the invitation. The reason we would like to tease out these non-ischemic cardiomyopathies, which sometimes are fairly obvious on the echo, is a very differing estimate of survival that is present in them. As you can see, some of them, like the peripartum cardiomyopathy, has a very good prognosis, and that because of HIV has a poor prognosis, and the rest of them are bunched in between. So it's very important to get to the etiological diagnosis. And then there are new devices and medication coming up in the market. And hitherto diseases which were not easily treatable, like amyloidosis, are quite treatable nowadays. Moving on to our first case, and this is a 71-year-old gentleman. He's non-diabetic, non-hypertensive. Came with gradually progressive shortness of breath for the last 4 months and orthopnea for a week. There was no chest pain, syncope, and he had ankle swelling. This was the ECG. You can see multiple ectopics. There is a intermittent atrial fibrillation, and he was then subjected to a 2D echo, and these were the findings. He had a biatrial enlargement. There was concentric LVH, moderate LV dysfunction, and a global hypokinesia. So with this history, ECG, and echo, what would be your provisional diagnosis? Could we have a poll? If there is any problem with the poll, let me know. I'll move ahead.
Sir, all of them voted for HCM, sir.
HCM. Okay. We'll move ahead now. Thank you for that answer. Now, the next step would be what? You thought about HCM, and these are the four techniques that you would like to use. What would it be? A MIBI scan, cardiac CT, right heart catheterization, or an angiogram, or a CMR. CMR is an MRI. You can go ahead and vote.
Sir, everyone has answered CMR, sir.
Okay, CMR, great, because we're talking about MR, that's really nice. Now, the CMR is indicated here because we have a biatrial enlargement that needs to be evaluated. There is abnormal left ventricular hypertrophy, and more importantly, we are looking for scar which is not available on the traditional 2D echo. Now, this is the first image of the MR. This is a Hayes sequence, and that's what we do initially. We cover the entire thorax. And what is important is you see a very dilated IVC hepatic veins with fairly thick chambers. So that's the first thing we look at. And we obviously know that the right heart pressures are elevated. So that's a very important clue that we get. This is the Hayes sequence. We do this before the contrast. Now, this is the cine stack, and MR is really good in getting you all the 4-chamber, the short axis here, the 2-chamber really well. And you can clearly see here, we're looking at a biatrial dilatation. There is a significant hypertrophy. Look at the septum. The septum is thickened. It's not very contractile. And there is an overall mild global hypokinesia, but the ejection fraction here was around 48%. It was about 42 on the echo. So, and we also have a thin rim of pericardial effusion around the heart, and there is the right pleural effusion. So very important findings here on the cine of the MR. And the next sequence is that we give gadolinium, and this is what we see. And this is very, very interesting. Now, the red arrow is showing you the gadolinium deposition here. It's all around the ventricle. It's there around the atrial walls. This is the left atrium, and this is the right atrial wall. It's thickened, and there is a lot of gadolinium enhancement even in the interatrial septum. This gadolinium is distributed uniformly throughout the ventricle. And it is better seen in this picture. Again, the red arrow is showing you that gadolinium accumulation. And when we look at the short axis, we see a very classical image of LV cavity, gadolinium, and the myocardial wall. From the base to the apex, these are the post-gadolinium images, very, very classic. And this is a blown up image of one of the short axis slices to show you the cavity, which is not fully blackened out. It's grayish. You see the gadolinium uptake and the wall around it. Now, with these pictures, I come to the next question as to which among the following would most probably fit the diagnosis of this patient: amyloidosis, sarcoidosis, DCM, or IC. You can vote now.
Sir, everyone has voted for sarcoidosis.
Sarcoidosis. Okay. Now, if you voted for sarcoid, what would be your next move? A TC pyrophosphate scan, a bone marrow, an EMB, or an angiogram?
So everyone has voted for EMB.
Okay. Now, coming back to this case, this is a fairly classic case, and this is a very classic picture I hope you will take back with you. In a patient with a biatrial dilatation and a concentric LVH, the misleading thing here was the patient had an LV dysfunction. Usually they have a preserved function, but this picture post gadolinium, we call it the bull's eye image because of the cavity, dark cavity surrounded by the light gadolinium and the dark wall. This is very, very characteristic of amyloidosis and amyloid deposition in the ventricle. This is a very classic picture, and this is another classic picture, a 3-chamber view post gadolinium showing you the global subendocardial deposition of gadolinium and the atrial involvement that is there, very classical in amyloid. If you get this picture, you would almost not have to do a biopsy, at least to prove the diagnosis. So this is classical amyloid, not sarcoid. And the next step for me would be to do a TC pyrophosphate scan because of the age. Had this patient been younger, I would have thought of an AL amyloid and I would have proceeded with a bone marrow and an immunofixation study. But because of his age, I will change track and go with a nuclear scan. And this is what I will see. This is a grade 1, 2, grade 0, grade 1, 2, and 3 of the technetium pyrophosphate scan. And this image here, which I'm pointing, is very classical for ATTR amyloid. So this case was an ATTR amyloid, and you know there are fairly good medication that are now available which can be used in these patients. And MRI is a very good tool to monitor the progress, and you will find the hypertrophy comes down, the gadolinium deposition comes down, and if we catch them early, they have a fairly good recovery. The second case is a 32-year-old lady. She has no comorbids. She has a classic slowly progressive shortness of breath, class 1 to 3 over the last 5 to 6 months. She was treated like a HFpEF patient because her 2D echo revealed a biatrial enlargement, concentric LVH, good LV function with no regional wall motion abnormality. Now, what would be your presumptive diagnosis for this young girl? These are your options.
Sir, people have voted for RCM, sir.
RCM, excellent. With a good LV function and a biatrial enlargement, the first thing would be to have an RCM. We will skip this in the interest of time, and we went ahead with the MR. And again, this is the Hayes sequence. This is the first thing that we do, and you can clearly see here that there is a mild pulmonary artery dilatation. There are no lymph nodes here. And moving on, again, we see the classical systemic venous dilatation, which is very classical of an RCM. And this is the cine pictures. You can see the function is good. There's an interatrial hypertrophy. There is an interventricular hypertrophy. There is hypokinesis of the interventricular septum. And you can clearly see here the lateral wall contracts very well. And this phenotype is that of a preserved ejection fraction heart failure, and RCM would be the likely diagnosis. This is again a 3-chamber view, again showing you the same thing. And you can also see this patient has a mild to moderate mitral regurgitation as well. And this is the two-chamber view, again showing you a fairly well-preserved ventricle with a dilated atria and normally functioning ventricle. So we went ahead and did the MR. This is the T2 weighted sequence. This doesn't show any edema as expected. There is a trace pericardial effusion. And this is the post-gadolinium delayed enhancement. And for your convenience, I'm going to point out to the pathology. White is dead or white is abnormal. And this is post-gadolinium delayed enhancement. You can see that it is sort of in the mid-myocardium, surrounded by healthy normal myocardium, and it's there mostly in the septum. But when we did the short axis slices, again post-gadolinium, we could see traces of patchy gadolinium enhancement all around the ventricle in the base, the mid, and also in the apex here. You can see the white is the gadolinium enhancement. It was not very typical, not very really clear, but there it was all around the ventricle. So in this setting, what would be your final diagnosis? So if you have the answer.
So people are divided onto RCM and HCM.
Okay. So yes, so you have a ventricle which is hypertrophied, you're right. In fact, the RCM should have been amyloid, but forgive me for that. Now, if you look at the classical deposition here, there is a hint that it seems like that of a HCM. In fact, we were also a little stumped. But here the septum is not, it is not asymmetric. It's a concentric hypertrophy. And if you look closely at the short axis, the delayed enhancement is global surrounding the ventricle. And it can be seen here also very well. It is a little less prominent in the inferior and lateral walls, but very prominent in the septum. We also had the same confusion, and this is what we did next. What would be your choice in this kind of situation where we are not sure? A pyrophosphate, bone marrow, EMB, or angiogram?
So we are having some problem with the poll. So can we just
Okay. So in such a situation, we also resort to something called a virtual staining, and this is called a parametric T1 map. And you can clearly see here, if you do it well, you're able to differentiate some of the non-ischemic cardiomyopathies like HCM with amyloid. Amyloid has possibly the highest T1 values apart from an MI, and also a very high ECV. And this is what it looks like. This is a normal patient, and this is a patient with amyloid with a very high T1. You can see that, and they also have a very high ECV. Both these two constitute a very large extracellular volume, and there is data which shows that the clinical outcomes are also projected by the ECV that is present. So if you have a lower ECV, you have a better event-free survival compared to somebody who has a fourth quartile or a high ECV. The survival is lower, and that is also very, very clearly seen. So not only in terms of the diagnosis, but in terms of prognosis, this is important. Incidentally, this patient did undergo an EMB, and we found classical amyloid in the septum, and this patient was treated for the same. It's very important to alert your pathologist to what you're sending, because they need to also look with the polarized microscope and see the green birefringence, which is very classical for amyloid, and also do the immunochemistry staining. Coming to case 3, this is a 25-year-old lady with shortness of breath, class 2 to 3, no other symptoms. Her echo showed a biatrial enlargement. There was a dilated left ventricle with global hypokinesis and severe LV dysfunction. What would be your diagnosis? If we don't have the pole working, I will go ahead. Our initial thoughts were DCM versus sarcoid. We didn't think of ICM because of our age, and amyloidosis usually has a preserved LV function. The next step, we went and did a CMR, and this is what it looked like. In the haze sequences, we could see significant hyperintense areas, and these were the mediastinal lymph nodes, which were very, very prominent. And the coronal section again showed a significant mediastinal carinal lymphadenopathy. And this is the cine images. You can clearly see that there is a left atrial enlargement, there's a left ventricular enlargement, there's a right atrial and right ventricular enlargement with significant regurgitation. And there is a regional wall, but it is not in the vascular territory. It's more of a global hypokinesia. When we did the T2 images, we found that there was a significant hyperintense area in the T2 map, suggesting that there is myocardial edema. And the post-gadolinium again showed a mid-myocardial septal delayed enhancement. The arrow shows it, and also a subendocardial lateral wall enhancement post-gadolinium. And this is again very clear in the three-chamber view, the septal delayed and the lateral wall delayed enhancement. So the final diagnosis was a patient with inflammatory cardiomyopathy, most probably sarcoid. And we also do know that apart from the diagnosis, the very presence of delayed enhancement in a patient with a sarcoid puts them at a very poor prognosis in terms of events. The next step in this patient was to do a lymph node biopsy, and the lymph node biopsy returned with a non-caseating granuloma. In our country, in our center, we generally treat all our patients with ATT initially. By the 12th week, we usually get the culture of the biopsy, and that revealed that was negative for Mycobacterium tuberculosis, and hence the patient was continued on steroid and azuran therapy. Now, my last case is a 35-year-old gentleman. He presented with multiple episodes of palpitations over 6 months, diagnosed to have an RVOT VT outside. An ablation was done at another center. Within a month, he had recurrence of VT with multiple morphologies exiting predominantly from the infraposterior septum. He had an elevated ESR and CRP. And for those of you who are EP folks, this is an EP tracing from my EP colleagues, and it clearly shows a refractory VT of multiple morphologies. So what would be your provisional diagnosis be? So if the pole is not working, we went ahead with a working diagnosis of sarcoid. And the next step was to do an MR, as you have guessed. And again, here you can clearly see there is LV dilatation, there is a mitral regurgitation, RV dilatation, there is a classical septal mid-myocardial scar, and also a lateral wall delayed enhancement. And as you've already seen, this patient had nodes in the mediastinum. So we went ahead and did a lymph node biopsy, and we subjected this patient to a PET. And this is what we saw: a significant myocardial uptake with nodal uptake and also thyroid uptake. And this patient had a very stormy course. Started off with a query RVOT VT, was managed medically with the standard antiarrhythmic medications of amiodarone, beta blocker, and xylocard. We caught him at the stage of MRI and PET. We thought it was sarcoid, did a biopsy. Because the VT was just not able to be controlled. ICD was put in, the drugs were increased, mexiletine was added, disease-modifying therapy, methotrexate, cyclophosphamide was added, overdrive pacing was done, patient did not respond. He had an endo and epicardial RFA, then went on to have a stellate ganglion block, multiple shocks during this period, And then finally, with the biopsy, we zeroed in on to one of the TNF alpha blockers, adalimumab, and then finally we could see light at the end of the tunnel. And this was the first ECG which showed starting of a sinus rhythm. This patient was continuously in ventricular tachycardia.
Excuse me, sir. So
Yeah.
we will have to wrap it up, sir.
Yeah, that's it. That's all. That's my last case. So we did a post CT in this patient, PET CT, and this is the first CT showing the nodal and the myocardial involvement. And here you can see the patient is free of disease and also free of VT. Thank you very much for your kind listening.
Thank you, sir. I would request Dr. Burkule sir to.
हो गया ना सारा
Yeah.
करेक्टेड आपके पास?
Is my screen visible? Is my screen visible?
Yes, sir, it's visible.
You're audible, sir. The screen is visible.
Audible, yeah. So dear friends, let us look at the cases of myocarditis, and we are looking at the imaging from a clinician's perspective. So I'll start with the acute myocarditis. Has got a very abrupt onset of tachy and bradyarrhythmias. You have a very abrupt onset of heart failure. You have got a lot of dynamic ECG changes, and so also imaging changes, which actually change every day. And so let us look at one of these cases. Now, this particular patient was a 42-year-old previously healthy lady. She had retrosternal severe burning and vomiting for 24 hours. She never had any fever or flu-like symptoms, non-diabetic, no pericardial rub. The troponins were very high, CPK-MB was high. Her ECG was showing right bundle branch block with ST elevation from V1 to V3. So obviously she went through a STEMI pathway looking at this ECG and a severe chest burning. Her ECG was quite dynamic. The next ECG on 7th showed QS pattern with ST elevation. The 2 days after the ECG showed the broad cardia. Her angio was perfectly normal. This is the left system, this is the right system, perfectly clean coronaries. Her echo on presentation, the EF looks good. The 2 days after, the EF looks slightly reduced. On 9th, the EF looks further reduced. But all this time, the LV is not dilated. The LV wall thickness is preserved, and that is probably because of the myocardial edema. If you look at her GLS map, now these are the longitudinal strain images, and this is the map on 5th, this is the map on 7th, this is the map on 9th. And you can see that this is quite a variegated appearance, and there are a lot of dynamic changes in the strain in various territories of myocardium, which are not restricted to any coronary territory. And so the thing is, the echo features of myocarditis are there is a normal cavity size, both LV and LA, because there is no time for any remodeling. There is increased LV wall thickness because of edema. There are wall motion abnormalities which can be focal or global. There can be a small pericardial effusion. The strain maps look variegated, and all these keep on having dynamic changes. Now so we'll go for this patient CMR. Now, before going to CMR, most of the clinicians get bogged down by these terminologies like T1 mapping and T2 mapping, or T1 weighted images, T2 weighted images. Now, in a very, very simple term, as you enter the CMR gantry, your tissue gets magnetized and the entire magnetic vector goes head to foot. And then when you start scanning the patient, you give them a radio frequency pulse and topple that vector horizontally. Now this vector, which is quite coherent initially, takes some time and then becomes completely out of phase. And this time is called T2 time. Generally, it is around 40 milliseconds. It will vary for a myocardium. It will vary according to the type of tissue. And then the whole magnetization returns back to its steady state level, and that time is called T1 time. It will also vary for different tissue. It also varies according to whether it is a 1.5 Tesla MR or a 3 Tesla MR. A 3 Tesla MR will give you T1 values in the range of say 1150 or 1200 milliseconds. Now the T1 values will be always more than the T2 values. And if you look that the fat has the lowest T1 value, followed by the myocardium has got little higher, and the water has the highest T1 values. And for the T2, it is other way around. The myocardium has got the lowest T2 values. The fat has slightly higher T2 values, and water has got the highest T2 values. And what about the gadolinium? Now you must have heard this jargon of late gadolinium enhancement, as we know that the gadolinium gets out of the capillaries into the extracellular volume. Now in the normal myocardium, it cannot enter the myocytes, and the extracellular volume is small, and there are good capillaries, so the gadolinium gets washed out. However, if the myocardium is necrosed, the gadolinium can enter the myocardium. So also, if there is a lot of extracellular edema, fibrosis, inflammation, exudation, infiltration, there will be a large space in which the gadolinium can diffuse, and it will not get cleared. And that is what we call as the late gadolinium enhancement, or the late gadolinium signals. So this is our patient, and this is the short axis and the 4-chamber view. And this is the T2 weighted image, which shows the myocardial edema. And these are the late gadolinium signals, which show you a lot of retention of gadolinium throughout the myocardium. Now, these are the classical Lake Louis criteria in 2010, and now we have moved to the new criteria. Now, this case is a very old case, so we use the classic Lake Louis criteria, which propose that you should have either regional or global increase in T2 signals. That means there should be water in the myocardium. That means there should be inflammation, edema. Second thing is that it should have early gadolinium enhancement with the first pass. That just tells you that there is a lot of inflammation and exudation of the edema of the gadolinium into the interstitial space. And also you should have late gadolinium retention, telling you that there is some amount of necrosis. But now we have moved ahead, and that I will show with a newer case. Now, this is a 16-year-old boy. He had a history of viral fever 1.5 months back. He was gymming, and when he had got backache, chest pain, and then he was rushed to the hospital with shortness of breath. He was in pulmonary edema. He was put on a non-invasive ventilation. And this was his ECG at presentation. He had a complete heart block with right bundle branch block, which immediately changed to a complete heart block with left bundle branch block. He was put on a temporary pacemaker wire, but the next day he had a narrow QRS VT, which needed a DC cardioversion. He reverted back to a normal sinus rhythm with narrow QRS complex, but the central monitor continued to show runs of ventricular tachycardias. Now, this was his echo, and you can see that there is actually the myocardial thickness is very well preserved. There is a mild reduction in the ejection fraction of this patient, mild global hypokinesia. And this is his GLS map showing some areas with a low strain values, a little variegated looking one. And this is the CMR cine images, also called as the steady state free precession. And this is the global longitudinal strain by the CMR feature tracking. The way we do on the echo, the speckle tracking, there is a feature tracking on the MRI. We show a very low GLS of -14%. You have a global hypokinesia with myocardial thickness very well preserved. And then we'll go for the mapping of this patient. Now, before we go to the mapping, let us know what are these parametric maps. Now, what the software does is that it measures the T1 values or the T1 relaxation values for each and every pixel in the image, and then assigns it a value. Now, that value is depicted according to the color bar. So it is similar to our, say, strain maps or our color Doppler, where the velocity is given in the form of color maps. Here the T1 values are spread out as per this particular color map. The higher values will be lighter, lower values will be darker. So also you can do T2 maps where every pixel is given a color coding according to the T2 value of that particular pixel. Now we'll look at our patient, and this is the T1 map of this patient, and you can put regions of interest and can look at their T1 values, and you can see that T1 values are all over the place. Somewhere it is reaching even 1500, 1400. Now these amount of And also you can look at the map that there are a lot of changes in the color in the myocardium. Now these lighter ones are where the T1 values are high, and as you know that the trapped water will have a very high T1 values, so that these are the areas of inflammation. And then we'll look at the T1 maps before giving gadolinium and after giving gadolinium. Now you know that the gadolinium will be trapped in the myocardium if the extracellular volume is high. So the gadolinium is there in the cavity. So looking at as we know that we can calculate the extracellular volume of the blood because we know the hematocrit. So using the ratio of these signals of the blood pool versus myocardium, we can calculate the extracellular volume of the myocardium, and that extracellular volume of our patient is very, very high. It is 38%. And you can also see the extracellular volume map here, where the higher extracellular volume is shown by the lighter colors, and you can see that there are areas where there's a lot of extracellular volume expansion, telling you that these are the areas of inflammation and edema. Then this is the patient's late gadolinium enhancement, and you can see there are so many areas where the gadolinium is retained in the myocardium, in the epicardial surface of the lateral wall. You can see it through the short axis stack and also in the long axis views, telling you that there are areas where there is a necrosis, there is a inflammation, exudation, so that the gadolinium is not getting cleared from those areas. So now we are more into the newer criteria, electrolytic criteria of 2018, where now the maps get quite hierarchy, quite higher value. So for edema, you can show it by higher T2 maps, and the injury you can show by the higher T1 maps. So also you can use the T2 stir images for the edema, or also you can show extracellular volume expansion or late retention for the injury purpose. And you should have supportive evidence of an LV dysfunction and pericarditis in the form of some amount of pericardial effusion. So this patient satisfies all these main criteria and supportive criteria for the of this electrolytic criteria 2018. So before going to the question time, I will show you a third case, and on which we'll go for the questions. He's a 44-year-old male. He had a new onset of bronchial asthma for last 7 years, for which he is on steroid inhalers. He has a cough, weight loss, fever, malaise for the last 2 months. He was admitted with heart failure and a large pericardial effusion, which was TAP, and the pericardial fluid surprisingly had a lot of eosinophils. He had a readmission within 2 months with heart failure. The bone marrow showed a lot of mature and precursor eosinophils. There was no evidence of any hematological malignancy, but this was a clear case of hypereosinophilic syndrome. And this was his echo, which shows a global hypokinetic left ventricle. And interestingly, look at the GLS map, which has got an apical sparing, though we are always taught that this is apical sparing is something which goes with amyloid. But obviously this patient is a hypereosinophilic syndrome, where we are looking at a eosinophilic myocarditis. He has got quite well preserved apical strengths. Let us look at the MRI, and the EF is 60%, looking at the short axis and the long axis here. And this is the feature tracking GLS, which is 9%, and which is an agreement with the echo. And so we are looking at a case of an eosinophilic granulomatosis with polyangiitis, previously used to be called as Chuck-Strauss syndrome. And so we'll look at the T2 maps, and just carefully look at these T2 maps. This is the basal slice, mid slice, and the apical slice. And you can see the bull's eye plot of all the T2 values, which go all the way from 52 to 45. And this is my question, whether the T2 map suggests a myocardial edema, a myocardial infarction, or all of the above. I think the poll is not working, but let me zero it down.
Sir, half of the people went for myocardial edema, half of them say all of the above.
Okay, it should not be all of the above, because as we know, the T2 maps are actually created or are used to look for the water trapped in the myocardium, because water has the highest T2 value. And what is water trapped in the myocardium is edema. So this is to look at the edema. So there are areas of myocardial edema, and these are seen by different colors and also on the bull's eye plot. So we'll look at this patient's T1 map, again the basal slice, mid slice, and the apical slice, and this is the bull's eye, and you can see the T1 values. And for our scanner, a normal T1 value is 1150 plus or minus 35 milliseconds. And here we can see the T1 values all over the place from 1500, 1300, so on and so forth. And so let me ask the question whether this T1 map suggests a myocardial necrosis, myocardial edema, myocardial infiltration, exudation, or all of the above.
Sir, audience is saying myocardial necrosis.
Actually, it should be all of the above, because T1 values are very non-specific. You know a normal T1 value for a myocardium or the myocardial proteins. However, whenever there is a myocardial necrosis or edema, water will increase the T1 values. So also when there is an infiltration, exudation, that will also increase the T1 values. So actually it is a sum total of all the pathological changes happening in the myocardium all put together. So this is all of the above. And then this is the late gadolinium enhancement sequence of this patient with EGPA or eosinophilic granulomatosis with polyangiitis. And you can see there are multiple areas, or you can see the myocardium is almost looks like moth-eaten. Okay, and my question to you is, what does this LGE shows? A focal myocardial necrosis, a myocardial infarction, an amyloid infiltration, or sarcoid? And this is the last question.
Sir, 33% of the patients say amyloid, 67% say sarcoid.
It's not so. See, the thing is, see, finally, it's the thing is, you have to put the clinical picture in perspective. Now, these are eosinophilic granulomas, so obviously there will be focal late gadolinium enhancement, but we also had that some amount of edema. We have got that history. We have got eosinophilia both in the bone marrow, in the peripheral cells, and we had the pericardial effusion showing full of eosinophils. So we know that these are eosinophilic granulomas. Now, infarctions are always will be in a particular coronary territory. They will be subendocardial or transmural, but restricted to certain coronary territories. The amyloid infiltration, as shown by Dr. Christopher, is very classical. There is very difficulty of nulling the myocardium. There is a loss of signal in the cavity, and the LG is subendocardial or sometimes even transmural, not respecting any coronary territories. Sarcoid generally will have predilection for the basal part of the septum, RV free wall, or even sometimes in the lateral epicardium, but in or even somewhat in the inferior wall. But in putting the picture together, I think these were the eosinophilic granulomas. Thank you.
Thank you so much, sir. I would request Dr. Milind Desai to take the floor.
Good morning. Can you hear me?
Yeah, your voice is loud and clear.
Can you see my slides?
Yeah.
All right. Thank you so much. My name is Milind Desai. I'm from Cleveland Clinic in Cleveland, United States. And I've been tasked to talk about a few cases related to hypertrophic cardiomyopathy and non-compaction. Here are my disclosures. So we will start with this case. All these are my patients that I've seen over the years. This is a young patient with exertional dyspnea and syncope, 21-year-old male. He has always been told never to participate in sports, multiple family members with a diagnosis of hypertrophic cardiomyopathy. Uncle had surgery for that, one aunt with sudden cardiac death, and the patient is gene positive for one of the genes associated with hypertrophic cardiomyopathy. He's on appropriate medical therapy and vitals are stable. Examination shows a harsh upper sternal systolic ejection murmur, which increases with Valsalva. And these three panels show images of echocardiogram. At bottom left is obviously most of us will recognize a very thick basal septal reverse curvature hypertrophy. The middle panel shows evidence of outflow tract obstruction with a posteriorly directed jet of mitral regurgitation, and the bottom right shows this very characteristic dagger-shaped, late peaking Doppler signal suggestive of severe outflow tract obstruction, dynamic outflow tract obstruction. So this person undergoes CMR. We've seen the technical aspects of CMR well described in the previous talk. So I'll just keep it very clinical. In here, what it shows is top left is it confirms what we saw on echo with very, very thick basal septum, very thick interventricular septum in a reverse septal curvature. The bottom left is similarly in a short axis pattern. And the CMR, the middle panel, and the middle panel shows significant, the white areas within the LV myocardium are very consistent with a significant amount of scar. The important thing is not just to look at scar, but to able to quantify that. And the two images on the right, top and bottom, demonstrate that the person has significant myocardial scar. There is an area of what we think is normal myocardium, and once you threshold it to normal myocardium, the areas of scar light up. In this case, the person had about 21% fibrosis at 6 standard deviations. The person was symptomatic, had a lot of scar burden and a lot of outflow tract obstruction. So he underwent surgical myectomy and also had a defibrillator implanted. This patient I've been following for more than a decade. He's still doing great without any recurrence of symptoms. No ICD discharges. So CMR has added value in HCM, sudden cardiac death risk stratification. And imaging is important, but look at the 4 things that I've highlighted in red. Ascertaining the degree of LVH with 30 millimeters as a cutoff. And all of us know CMR is very accurate in measuring wall thickness. Of course, measurement of late gadolinium enhancement and a threshold of more than 15% of LV mass is associated with adverse events. Burnt out HCM with an EF less than 50%. And presence of LV apical aneurysm, which is occasionally seen in patients with apical HCM. So this is a paper we published a few years ago now, and the data has been replicated in other studies also, which demonstrates more than 15% of LV mass associated with sudden cardiac death in all types of HCM patients, obstructive, non-obstructive, people who had a myectomy, people who did not have a surgical myectomy. So this is considered, according to the guidelines, as one of the potential risk modifiers in HCM. But it is important not just to recognize LGE, but to understand at what threshold. See, MRI and any imaging technique, you can adjust the thresholding and have whatever number you want to look at. So in this publication from a few years ago, what they have demonstrated, and the images here show, if you have 2 standard deviation, then the entire myocardium looks like scar. If you have 6 standard deviation, that was most closely aligned to visual estimation in terms of fibrosis assessment. So at least in our lab, when we are making clinical reads, we are looking at things visually, but if we are quantifying, then we quantify and report it out at 6 standard deviations. We don't want to be oversensitive. We don't want to be under specific. We want to be just right. So moving on to the next case, this is a 25-year-old patient who had no documented past medical history and presents with palpitations and presyncope. No other symptoms. He's had a normal childhood, occasional palpitations, but doing well otherwise. Not obviously on any medications and no documented family history. Examination was essentially otherwise unremarkable, but if you look at the EKG, given his pre-syncope, the first thing obviously that was done was an EKG, which is markedly abnormal with significant LVH and deep T-wave inversions, especially in the lateral lateral leads. The middle panel confirms what we think would be going on, and there's a massive case of LV hypertrophy, mostly in the apex. And it is important, anytime you're dealing with an HCM patient, you go make sure they do not have an obstructive pattern. So we did provoke the patient, and he did not have any outflow tract obstruction. CMR, obviously, multi-parametric assessment was done. Again, the image on the left, top T2 weighted image, cine images, both of which confirm what we suspected on echo, suggesting very severe apical variant hypertrophic cardiomyopathy. Notice the patient has central significant mitral regurgitation and significant dilation of the left atrium. So you have to suspect that he may be behaving in a restrictive cardiomyopathy type, a restrictive filling pattern also. And a fair bit of myocardial fibrosis, which is mostly located in the apex. An important thing here is there's no LV apical aneurysm or LV apical thrombus. So the diagnosis, obviously, significantly increased mass index, massive apical hypertrophy with apical variant HCM, and LGE was around 17% of total LV mass, all in apex. This patient also had Holter monitoring, obviously, which showed short runs of VT that coincided with his episodes of palpitation. So patient was started on beta blocker, and primary prevention ICD was implanted. This person subsequently had genetic testing and cascade testing for family members and was found to be positive, basically MYBP3 gene, C3 gene. Unfortunately for the patient, or however you look at it, he's the only member in the family to be gene positive. So he apparently won the lottery for hypertrophic cardiomyopathy. Apical aneurysm, it is important to know that if you suspect somebody with apical HCM, you have to basically be on the lookout on echo as well as CMR to make sure there is no apical aneurysm. And if you have an aneurysm, A, it could be a risk factor for sudden cardiac death, and B, you could have a thrombus within. So there are two reasons why you have to be very careful about what you get when you have an apical HCM variant. It is no longer considered a benign form of HCM. I'm going to show you this case. Again, we saw this many years ago, and now this is established part of our practice. This patient is an 18-year-old with, most of you do some form of imaging, and in these 4 panels, what you are seeing is, why the heck is Desai showing you a image of a normal LV when he's giving a talk of hypertrophic cardiomyopathy? Well, as it turns out, this person has no hypertrophy, but the only thing he has is a very prominent papillary muscle. Doesn't really matter, because when you provoke this patient, he also has severe outflow tract gradient and significant SAM with provocation. So the question is this HCM? There is a characteristic provocable gradient, but there's normal mitral valve and there is no hypertrophy, there is no H. This person was a gene positive patient with hypertrophic cardiomyopathy. So this is what we have recognized and written extensively about, non-hypertrophic variant of HCM. Patient was symptomatic, we provoked the patient, he's positive, he's also gene positive. This person underwent papillary muscle reorientation and he is doing very well. So this person could not undergo surgical myectomy, and so we had to develop a new surgery to fix this patient. Atypical outflow tract obstruction can occur in different flavors, so you have to be on the lookout. Not everything is about hypertrophy. The patient in the top panel has a elongated mitral leaflet. The patient in the middle panel has bifid hypermobile anterolateral papillary muscle, and the third patient has abnormal chordal attachment. All these three are variants of hypertrophic obstructive cardiomyopathy. You just have to be on the lookout for different patterns and be able to recognize that. And CMR helps really well in ascertaining what could be the underlying diagnosis. Moving on to the next case, you gotta keep your eyes open for everything. This is a 64-year-old male seen at our organization. Dyspnea on exertion occurs frequently, occasionally with positional dizziness. He's been told of a benign murmur for many years, not really followed up. He's got all the cardiac risk factors, and he's on what we think is appropriate medical therapy. He does have a murmur. So the EKG on the left bottom shows some non-specific STT changes, but otherwise nothing. The echo shows basically there is a suspected LV wall motion abnormality, but also patient has systolic anterior motion of the mitral valve, which is confirmed on these Doppler images, which shows outflow tract turbulence with posteriorly directed jet of MR. So this person has what we thought was LAD wall motion abnormality, but also SAM. And with amyl nitrite inhalation, the SAM to septal contact increased, and there was a dynamic outflow tract gradient of 73 millimeters of mercury. CMR, obviously we did that, which confirms basal septal hypertrophy, but also what, as you can see, thinning out of the distal LV septum on 4-chamber and 2-chamber view. 3-chamber LGE demonstrated a thin rim of myocardial delayed hyperenhancement. This was not in a standard non-ischemic cardiomyopathy pattern, but we thought it was more in an ischemic pattern, suggesting that the person may have two things going on. So our diagnosis on CMR was this person most likely has HOCM with suspected CAD. Sure enough, he underwent left heart invasive angiogram, which revealed multivessel coronary artery disease. And the person, obviously, we did not do a stress test on this person because that would not have been a very good idea. He underwent septal myectomy, mitral valve repair, and multivessel coronary artery bypass grafting. So you have to keep your mind open. Patients come with multiple diagnoses. Last case, a young girl with frank syncope and aborted sudden cardiac death, 17-year-old female. She had an episode of witnessed arrest, bystander CPR, underwent CPR on the field, and was shocked with the return of spontaneous circulation. Rhythm was found to be a VFib. There was no documented family history. Now doing well. Contrast echo maybe raises possibility of potential non-compaction. Clearly, person underwent multiparametric cardiac MRI, which confirmed that there is significant amount of trabeculation in the lateral wall as well as infralateral wall on multiple chamber views. There was no myocardial fibrosis. EF was thought to be around 32%. What we did was we measured the ratio of non-compacted to compacted LV at diastole, which was in this context more, it was around 2.8. There was no concomitant LV thrombus. So we were very confident in the diagnosis of LV non-compaction. We placed a secondary prevention ICD. Patient is unfortunately on guideline-directed medical therapy and in the process of getting a heart transplant. So non-compaction, this is rare, but with advanced technology and imaging, it is being increasingly recognized. And based on the important thing here is on CMR criteria, a ratio of more than 2.3 in diastole has a high diagnostic accuracy in terms of making a diagnosis of non-compaction. Unfortunately, not enough is known about this, but the prognosis generally remains poor, and most patients end up needing cardiac transplantation. So I think I'll stop here with the cases, and I can share my multiple choice questions now. Can you see my multiple choice questions? So the first question is, in hypertrophic cardiomyopathy, based on current literature, what is considered to be the cutoff of myocardial fibrosis, which increases the risk of sudden cardiac death? Is it 5%, 10%, 15% of LV mass, or 20% of LV mass? Questions or answers?
So give us a moment. We are just putting through the question.
Yeah. Answer? I can go through the questions. Do you want me to go through the questions? Just
Tell him all the people answered 15%.
perfect. That's great. So everybody's paying attention. There's no post-lunch siesta here. So as I showed you, HCM guidelines also suggest a 15% LV mass or higher. And this is our paper showing that from a few years ago. Question 2, in assessment of myocardial fibrosis on CMR, what thresholds over remote normal myocardium is closest to visual inspection? 4, 6, 8, or 10 standard deviation. This should also be easy.
One, yeah.
Answer?
The 1/3 have answered 4, 1/3 6, 1/3 8.
Oh, terrible. Wow. The answer is 6 standard deviation, as I showed in the slide during my case presentation. This is based on this paper that was published in 2011. This is why, especially if this is a majority of electrophysiology crowd, you are the consumer of technology. You are not the radiologist, you are not the imaging cardiologist. So it is important when you get the report of how much scar there is, how much fibrosis there is, you ask your referring or your radiologist or cardiologist as to how they are measured, because the values can vastly differ based on what thresholding you use. And you don't want to be putting in the defibrillator wrongly in somebody who does not really need it. So this is important to remember. Question 3, in non-compaction cardiomyopathy, what ratio of compacted to non-compacted to compacted LV wall has the highest accuracy in making the diagnosis on CMR? Is it a ratio of more than 2.3 in diastole, ratio of more than 2.3 in systole, ratio of more than 3 in diastole, or ratio greater than 3 in systole? The answer is?
So 2/3 of the people have answered ratio of more than 2.3 in diastole.
Yeah, so that is indeed the correct answer, as we had discussed. ECHO has slightly different criteria, but in 2021 and beyond, CMR is the gold standard for accurate assessment of a non-compaction cardiomyopathy, and I would refer to the guideline document that I highlighted for assessment of non-compaction. And this was published into the ARVC guidelines. There's the cardiomyopathy guidelines published in 2019. And we have published a review on non-compaction a few years ago from the Cleveland Clinic. Question 4, apical HCM, presence of apical outpouching is considered to be a sudden cardiac death risk factor. Is it true, is it false, or there is no relation to sudden cardiac death? Answer?
So everyone has answered true.
Perfect. So everybody's paying attention. So that this is important to recognize, because now with advanced technology, you are recognizing more and more variants of hypertrophic cardiomyopathy. And if you see mid or distal LVH in the context of HCM, you have to make sure you think about an apical aneurysm or outpouching. And if you see it, you have to look for a thrombus. And if you see it, you have to consider that as a risk factor for sudden cardiac death. I think that's, and this is based on emerging data plus this paper published a few years ago. I think that's the end of my conversation. Thank you so much. Merry Christmas and Happy New Year to everybody. Stay safe.
Thank you very much, all the speakers. It was indeed an excellent talk. Am I audible to everybody?
Yes.
Hello? Yeah. So it was an excellent talk by everybody. I think we had an in-depth discussion on this role of CMR in various kind of cardiomyopathies. Dr. Bhavin Jankaria told about the arrhythmogenic right ventricular dysplasia, and also to some extent regarding the arrhythmogenic left ventricular dysplasia. Dr. Johann Christopher talked about the amyloidosis and sarcoidosis and the role of CMR in identifying them. Postdoctor Gurkule gave an in-depth knowledge about step-by-step diagnostic features in the CMR from basic to advanced. He talked about that very interestingly about the hypereosinophilic syndrome and explained everything. I think the audience will have a very clear knowledge on the CMR and different cardiomyopathies. And finally, Dr. Milind Desai gave excellent talk on hypertrophic cardiomyopathy. So wonderful session. I don't have the access to the audience questions. Do you have Bhama event the access to the audience questions? Anybody wants to? Hello?
On the chat box, there are no questions at present.
There are no questions. Okay. In the absence of any questions, I'll put one or two questions to the esteemed speakers. Maybe after that, we will end the session. Hello, Dr. Milind Desai. I am Dr. Dora from Mumbai. It was excellent talk by you about the hypertrophic cardiomyopathy. And I know you have a lot of work on that. Recently, I had a patient who is around 40-year-old. His father died at the age of 40. And of course, that cause was not established. Most likely, maybe hypertrophic cardiomyopathy only. This person is having very mild symptoms, completely asymptomatic. The CMR scar burden is less than 15%, around 12 to 13%. Holter is normal, has absolutely asymptomatic, little hesitant for any further investigation. So what is the, what will be your advice? Should we go for EP study? Should we go do the genetic testing? Or he should go for straight away ICD implantation for primary prophylaxis from sudden cardiac death?
So this person has an immediate first-degree relative with sudden cardiac death. So that puts him in a rare high-risk category. Yes, on the bright side, his CMR does not reveal significant scar. So that's a good thing. But you know, the CMR in the hierarchy of risk stratification, I would put that a little lower than the father dying of sudden cardiac death. And just because he had a Holter monitor is for 24 or 48 hours. So we don't know whether he's having non-sustained VT. So at the very least, I would have a frank conversation with him and say, you have a bona fide one risk factor, and I would recommend a primary prevention ICD. If he's a bit hesitant, then certainly I would do everything in my power to diagnose the arrhythmia. And in my practice, I've occasionally done Zyopatch or what you call the link device, the internal loop defibrillator, the loop recorder device, to prove or disprove. The other thing I would do, not may, I would do to provoke symptoms or what have you is to put him on a treadmill. I would do a stress echo on this patient to see what is his exercise capacity, as well as does he have exercise-induced any arrhythmias that he would see. So my vigilance of him should be substantial, especially if he's unwilling to proceed with an ICD. I'd be doing full investigation, making sure I'm not losing anything or not missing anything.
Yeah, I think I completely agree on you. And he, in fact, had a stress echocardiogram, and which was, of course, normal. Didn't have any arrhythmia during that time. But anyway, he's still hesitant for EP study. I don't know whether the EP study has any role here, because a negative EP study again may not exclude him from
exactly. I've been practicing here for 16, 17 years as an attending physician at the Cleveland Clinic, and I have not sent a single HCM patient in my practice for an EP study for this. So, I mean, but that's just my bias.
Okay, yeah, that's I have a quick question. Another patient who is a 70-year-old lady, now 70-year-old, living with hypertrophic cardiomyopathy, and it's a concentric hypertrophic cardiomyopathy, and hardly there is any space in the LV, in the diastole, even in diastole, and she's severely symptomatic with heart failure symptoms. Now, of course, 70-year-old. What will be your line of management now? Whether you should leave it like that with medical management or anything?
Our 70 is young nowadays. 70 is
70.
Yeah, 70 is young. You know, people are living in the 90s. 70 is middle age, in my opinion. The older I get, more I think 70 is middle age. So, you know, she may, if she has hypertrophic cardio. So first of all, I would make sure I would rule out amyloidosis. My assumption is you ruled out amyloidosis. If this is just severe, the other possibility is hypertensive heart disease, like severe uncontrolled hypertension. And you know, HFpEF, treatment of HFpEF can be challenging. Now, if this person has severe symptoms, very small cavity because of massive concentric hypertrophy. We have, and if you think this is all driven by non-obstructive HCM, we have, and there is data from other organizations also where we have done a debulking myectomy where we would shave the muscle. I mean, I'm not suggesting this is the case in this 70-year-old, but we have done debulking myectomy where we remove some of the excess mass that helps improve the end systolic volume, which improves the stroke volume and has helped the patients from a symptomatic perspective. So different strategies. Obviously, the treatment for HFpEF is pretty much Lasix and wish me luck. So there's not much going on. If there is severe apical type HCM, we have done debulking apical myectomy. Other than that, you know, there is, and you got to make sure that they do not have amyloidosis or something else for which there is emerging data. Now, I will say this, there is newer precision therapies that are going to be available in the context of hypertrophic cardiomyopathy, these myosin inhibitors. Perhaps they may have a role in this disease from a symptomatic perspective. So time will tell. You're cutting out. I cannot hear you. I cannot hear you.
Hello?
Yes.
Yeah, sorry. Am I audible now?
Yeah.
Okay. Short of time now. We are nearing 4 o'clock. The next session has to start. There is a short break, and after the next session will start. And I'll thank again all our speakers, esteemed speakers. I'll thank the audience for the patient sharing. A wonderful session and a lot to learn. Thank you very much.
Thank you.
Thank you.